So in the time I have, I'm going to review alcohol use disorder, efficacy, and barriers to care. I'm going to talk about the different definitions of relapse. And define the difference in interventions for alcohol use disorder versus relapse prevention, and talk about the benefits and limitations of person and computer-delivered interventions. So for 25 years, I've been working on alcohol interventions, beginning first with brief interventions, and this is advancing without my pushing the thing, so yeah. I've been working with Betsy McCall, Dr. Betsy McCall, who's a professor here, and also Gitanjali Chander, who is an internist and who's now at University of Washington running, who's head of GIM. And thank you so much. And the three of us, we've developed, oh. I don't know why it's doing that. There's always a tech issue. So we've developed brief interventions for alcohol use, thank you, for heavy alcohol use, which doesn't quite yet meet the criteria for alcohol use disorder. And I've culturally adapted those interventions for use in Vietnam and also India. And then we've also worked in the area of alcohol use disorder treatment for alcohol use disorders. And now I literally feel like I've come full circle in working in relapse prevention, which is what I'll talk about today. Now, going back to COVID for a moment, this graph was published in the New York Times recently. And what's fascinating about this graph is that it shows that Americans bought $1 billion more of alcohol during COVID. And while it decreased with the end of COVID, notice that there wasn't really a reset back to pre-pandemic levels. I think this graph is pretty stunning. And even if you factor in the percentage of people who buy alcohol versus that 60% of the people buy most of the alcohol, it's quite a stunning graph. Now, just briefly, when you look, about 50% of people drink, if you look in the past month, and you note that women are the light blue bars and men are the navy blue bars. What's interesting about this graph is that it's showing that the prevalence of different levels of alcohol use disorder between men and women are converging. So younger men are drinking less alcohol, so that therefore men and women are catching up, and older women are drinking more alcohol, but they're converging. It used to be like at the turn of the last century, it was about 3 to 1. Now it's about almost 1 to 1 on most measures. I want to make 3 points about alcohol use disorder treatment. First of all, the evidence-based therapies, and you're familiar with all of them, cognitive behavioral therapy, motivational interviewing, contingency management, they all work. And there have been numerous reviews, Cochrane reviews, with a moderate effect size showing that they work. And they're pretty equivalent in their effect. So that's one. Number 2 is that pharmacotherapy plus evidence-based therapy works well too. In fact, it works better than either one alone. And then in the context of chronic liver disease, integrated treatments, especially as Pam described, are especially effective and necessary. And in the systematic review, there are rather dramatic statistics of 74% of people achieving abstinence compared to 48% in standard care. So treatment works. The problem is there is a huge gap in delivery of treatment. And I think these statistics really have not budged much in the 25 years we've been doing this work, which is that less than 8%, and these are recent statistics from NESARC, less than 8% of individuals receive any kind of AUD treatment in the last year, and less than 2% receive AUD meds. What I found pretty fascinating is there was a study recently amongst 60,000, so a good size N, of privately insured patients with cirrhosis due to alcohol-associated liver disease. And within 1 year of their index diagnosis, only 10% received mental health or substance use visit. And these are people who have access to care, so insurance is not a barrier. And 0.8% received AUD meds. Notably, as we've seen today with our patient, women were less likely to receive either of the interventions. But importantly, treatment would reduce risk of hepatic decompensation in women and men, regardless of whatever other comorbidities. So what are the culprits and barriers? They're the ones you can already guess. It's insufficient screening, insufficient provider time, in busy clinics, insufficient coordination of care, siloed clinics. You know, the hepatology clinic doesn't talk to the AUD treatment clinic. Stigma and reluctance are a big issue for patients, and of course access. And one other, which I encounter a lot, which is patients don't believe that treatment works. They won't necessarily tell you that unless you really ask them directly. And I want to make a special plea for women. There are culprits and barriers that affect women differently from men. So the rates of alcohol use disorder amongst women are rising more rapidly. And as you know, they developed alcohol-associated liver disease at lower amounts and faster rates than men. There's greater stigma for women. There's greater stigma for women just drinking, let alone if they advance to an alcohol use diagnosis. They have increased burden with childcare. Interestingly, they're less likely to have alcohol use recorded in healthcare settings, and they're overall less likely to interact with the healthcare system in the period prior to their diagnosis, as we saw from Pam as well. But severity aside, and this is important, they're less likely to seek treatment, but when they do, they have outcomes that are comparable to men. Now, we have another issue, as anybody who works in substance use knows, that relapse is a part of the plan. So the statistics are pretty much unchanged as well, 40 to 60%. It's actually a little bit better than it used to be, but 40 to 60% of people, and up But not surprisingly, thank you so much. Not surprisingly, they're lower in alcohol-associated liver transplant patients than other kinds of liver transplant patients. Now, one of the issues in relapse is the problem of definitions. So they did a study, they looked at a systematic review of 300 different studies on relapse, and they found 100 different definitions. And the definitions of relapse are largely driven by the context in which you work or think. So for the DSM-5, relapse is symptom-based, and I'm going to talk now, focus on the third column, which is remission and recovery. So remission is not meeting any criteria, except excluding craving. You can have one symptom, but excluding craving. Whereas the National Institute of Alcohol and Alcoholism defines recovery as remission plus cessation from heavy drinking. Now note that the DSM does not have any specifiers around amount of alcohol, and apparently there were two reasons for that. They couldn't get the models to converge when they were listing the criteria, but the other reason is the hope was that the DSM would be used globally, and the amounts of alcohol used in what constitutes unhealthy and healthy or lower risk drinking varies across countries, so they couldn't have that global application. In clinical practice, I think we all worry about not just whether a person returns to heavy drinking, but also whether they've gotten their life back together. So what's their quality of life? Have they reduced their risk of other negative comorbid conditions? Have they improved functioning on their job? And finally, AA, their abstinence is required in AA, but they also talk about spiritual transformation, and if you don't have that, then you're not considered really progressing in recovery. Now, I'm not going to go through this slide except to say that I grew up at University of Rochester, where George Engel was king, and the biopsychosocial model was how we thought about every patient, and it was great training. So I will note that now they've added spirituality to the model, so it's BPSS. The point of this is that there are so many factors that coalesce to produce relapse. And I use this kind of map with all my patients to think about what particular challenges they have, and they're myriad. So it's perhaps not surprising that the relapse rates are so high. A couple words about the difference between AUD treatment and relapse prevention. They're not the same, and I've made a list of all the different ways, and I could talk a whole lecture on that, but I won't. But treatment for AUD is about stopping. Treatment for relapse prevention is about maintaining low-risk use or remission or abstinence. And both of those definitions are now acceptable. It used to be abstinence only. Now, if a person can reduce to low-risk use, not so much recommended for alcohol use disorders, but reduce to low-risk use and maintain that, then that's acceptable. So avoiding relapse is important for AUD treatment, and in relapse prevention, it's more about managing the relapse and delaying the onset of relapse. In AUD treatment, medical and psychological treatment is important, whereas I feel like the world opens a little bit in relapse prevention, so it's psychological, behavioral, and spiritual, social too. The methods are often the same. Obviously, there's going to be detox involved in medical management and MET and CBT, as we know. But all those same methods are applied, the substance of them are a little bit different in relapse prevention. So it includes emotional and behavioral regulation, identifying high-risk situations. MBSR, mindfulness-based stress reduction, has become a very important and evidence-based technique for relapse prevention. And then, of course, using pharma is more about reducing cravings and supporting withdrawal, whereas pharma in relapse prevention is preventing relapse, but pharma is no longer the main focus. A couple other things. So alcohol use disorder treatment focuses, it's event-oriented. Stopping drinking is the first step, whereas in relapse prevention, drinking is the very last step. And one of my favorite techniques in relapse prevention is something called seemingly unrelated decisions or seemingly irrelevant decisions, if you all are familiar with that. It's a really interesting way of understanding that a relapse can actually happen over weeks or months. And what we need to do is to understand the chain of events that led up to the final drink, which may include taking a detour to the liquor store or near the liquor store where you know where the liquor store is, but you weren't really thinking about the liquor store being there, and you take that same detour home every week, and pretty soon you're stopping to park and pick up some groceries and eventually go into the liquor store. Understanding those are the seemingly irrelevant decisions, nuanced, sometimes out of our awareness, where we're leading back to relapse but not focused on it at the moment. Cognitive restructuring and alcohol use relapse disorder is I have to have a drink to cope, whereas you're challenging the patient's notion that I've been sober for 3 months now, or I've been low-risk drinking for 3 months now, I think I can drink like a normal person, or I can test myself and see how I can do. For alcohol use disorder, the mantra is avoiding people, places, and things, whereas relapse prevention says, no, you're going to go back into the situation. We're going to equip you with skills that are going to allow you to respond to stress, not react to stress. I don't like the word triggers because I feel like that communicates to the person that they're out of control. And one of the messages that you want to give to people is they're capable of managing and they can do the management, but you call it a high-risk situation or a cue, but something other than triggers, which is always a little, I was going to say loaded, but that doesn't sound quite right. Triggers is a little loaded in Baltimore, too. So your techniques in alcohol use disorder are delay, discuss, do something else, whereas relapse prevention is a lot about building self-efficacy. And finally, social differences. In early in alcohol use disorder treatment, you want to connect to other people who've been through or going through what you're going through. And here in relapse prevention, you're focusing more on building a social network, building what they call behavioral activation, which is a fancy word for building in new activities that provide you reinforcement that will replace your alcohol use. Now, a little bit on our projects. We have two that are person-delivered. One is a chapter in the Prosper study, which is here at Hopkins in the John G. Bartlett Clinic, Specialty Clinic, and that's a chapter and an overall intervention on substance use. And then the Hathi study, which is in India, where we developed an alcohol use intervention for HIV and TB patients, which I culturally adapted for use there, which is a really interesting process. And relapse prevention is one of the a set of sessions for people for whom that's appropriate. And then we have our computer-delivered projects. There are two. The liver transplant project, which you've heard about, which is, of course, Dr. Andrew Cameron and Dr. Betsy McCall are PIs. And this is delivered, I'll show you a picture of our avatars in a minute, but they deliver the counseling. And then there's extended computer counseling for the liver transplant patients, which they can do at home. But this is truly the integrated model. So there are follow-up visits with our study RN. There's psychiatry, Sarah Andrews provided the psychiatric consulting. There's a team of social workers, and as Pam said, they provide excellent care. So you're either randomized to our computer and nurse follow-up care or usual care, which is, of course, excellent. And then there aren't many computerized studies of relapse prevention, and so we were quite interested in filling that gap. So we have a head-to-head study that IPI at University of Washington, and I designed the computerized intervention, and then we have the person-delivered, which is exactly the same, and we'll compare that to usual care. These are our avatars, and I apologize in advance. I don't have a clip of our intervention, but Dr. Tanya Clark, Dr. Edna Poe, because it's Baltimore, and Dr. Lavinia Liven. You'll notice that they're all female and we've done a lot of testing, and this is found, globally working on interventions. Women avatars are seen as more approachable and trustworthy, and these cultural stereotypes align with seeing women as better health caregivers. And androgynous doesn't cut it because people spend a lot of time trying to decide who they're talking to. So people naturally want to focus in on a female avatar. This is what our user interface, we have a couple different user interfaces. This is one of them. So the avatar says, tell me about your reasons for drinking. If the person says, I drank because I feel sad, the avatar comes back with an empathic response and says, I'm sorry, life has been painful for you, or some empathic response. And it's okay, let's continue and talk more about your reasons. And then they go into pros and cons of drinking and then work on skills. So the computer-delivered interventions, by design, are non-judgmental and non-stigmatizing. They're easy to access. They're tailored to the user. So for our users, we have this incredibly complex branch chain. So the user has to respond using multiple choice because we are not yet this is not a video game where we can just easily do natural language, but we can travel down so many different branches depending on what the person says. So it's quite a complex structure by the time we try and anticipate every possible response and then branch them accordingly. So it's very user intensive on the beginning. But the good thing is we can also offer multiple languages. And for providers and clinics, it's actually incredibly helpful because it removes the burden of time. These are scalable, you can have broad reach. It assures consistency in the intervention, so everybody gets the same amount of information and skill building. I think in particular for people who are ambivalent about entering treatment, this is an opportunity to interact what looks like a therapist and hear some of the information that maybe they don't want to hear from their physician or other care providers, so that you can provide information in a non-judgmental way and impart some basic skills. We know that these computer-delivered interventions are effective for alcohol use disorder. There are numerous reviews. In our own work, we had 226 people from the HIV clinic who were not treatment seeking. This is important. So we kind of hit them over the head and said, do you want to review an alcohol treatment intervention? And they were sort of, we had some advanced information. So they were non-treatment seeking, they were non-incentivized, and they reduced their alcohol use by 11.7 drinks a week, which is huge. So not only statistically significant, but clinically very significant. And we just recently replicated this in a study. I don't have any results of our relapse prevention studies. It's going to be about 18 more months that are left on these various grants. But we've done extensive system testing, avatar testing. You notice the avatars all have big eyes because it's easier to talk with somebody with big eyes because they look more empathic. But I can tell you that as a result of our testing that the overall satisfaction is 4.75 on a 5-point scale, and we did achieve the non-judgmental avatar. People actually attach to the avatar. They attribute certain personality characteristics because we also ask them about that, like, what do you think Dr. Poe is like? And it's sort of interesting to see in ways in which people's opinions converge or don't. But their feedback has been interesting. They thought the program supported their goals. It's not personal. There's no one to judge you, which is what we hoped for and expected. Some people said, I'd rather have the computer counseling because it gives you control. But some people note it's a good place to start, but I wouldn't want it to replace my therapist, which is good news for the Department of Psychiatry. Interestingly, the final quote, they say a cartoon character makes it easier because they don't have facial expressions. If it's so easy to lift an eyebrow that we are not even aware of, that we'll read as judgment when we talk to our patients. And that whole possibility is removed with computerized interventions. I don't think they should replace therapists, psychiatrists, psychologists, social work, nursing either, but it's a great introduction. Interesting, the last quote always I included because I thought it was kind of interesting. The doctor is not better because they say if you don't do this, this bad thing will happen. Well, most people don't listen to their doctor anyway. And I think we've all had that experience at one point or another. There are challenges, and there are regulatory challenges. There's a digital divide, obviously, which we're concerned about. That's why we always do our interventions in the clinic where people can be supervised. I don't know how many of you have downloaded apps and then never used them, because unless you're checking in with, I have a dozen probably, because you need to have that supervision. You need to make sure somebody's going to get you on the tablet and walk you through the intervention. There are system malfunctions. Our avatars go out of style. Their hairstyles go out of style, or nobody wears that color anymore, so every couple of years we have to update our avatar. And as I said, the oversight. So I have a few thoughts on where to go from here. We've done talked with providers around the country about their screening for alcohol use. And while providers will, there's not enough screening. And when providers do screen, they're not using measures like the Audit C, which is a really easy measure to use to get a sense of what a person is drinking. And that allows you to compare over time if there are changes. I think we have to think about offering brief intervention, alcohol use disorder treatment, and relapse prevention. It's making it more accessible. I've been, this issue's been ongoing longer than I've been doing this work. I add this other point, the biopsychosocial care model, the importance of working together in an integrated fashion cannot be overemphasized. I believe that's why the liver transplant program here is so successful, because they work together. And patients, if there's a problem with a patient, there's a lot of people on deck to think about the problem from a biopsychosocial vantage point. We need to make space for ambivalence. I think technology offers a unique access to people who aren't quite ready to engage care, but you can give them a tablet and while they're sitting in the waiting room and give information, whether it's alcohol use, depression management, whatever. I think there are going to be some really exciting, probably some scary, but also really exciting movements in AI and machine learning and biosensors that will help us and also individuals recognize when they're at risk for relapse. So treatment works. We've still got to get that message out to our patients who assume often that it does not, and using integrated methods and the evidence-based methods. Thank you. Questions?
Wow, that was fascinating. I love that. We don't talk about alcohol enough in the department. That is, it's rare we have a grand rounds on alcohol. You sort of, yeah. Speaking for myself, I feel like there's an enormous amount to learn. So many interesting points you made. The less than 8% of people getting treatment, that is remarkable, and women seeking treatment far less than men is not something I was aware of. There's lots to talk about, but let me ask you this. Actually, before I ask you a question, let me ask everybody to, when we come to an end, I'm going to ask you to hang on for just another minute or two at the end. You've touched on this, but with regard to the computer, to the avatars, I mean, it's a fascinating thing that people like it so much and that it seems to work so well. And I think you've said right here in this last slide that it should be technology should be combined with person-delivered interventions. I imagine there's probably plenty of people exploring AI chatbots to treat alcohol use disorder.
Including us.
Including you, okay. Yeah, I was wondering if you could talk about that issue of combination versus going an AI-only direction.
Well, it's of course it's all about the money, right? And you know, when we show our computer-delivered intervention to young people, I think they're expecting video game quality computerized interventions. So I think what really needs to change with these computerized interventions is that right now we interact with, the avatar interacts through this multiple choice menu, which is a little, you know, it's not quite a natural exchange, and AI would actually allow us to circumvent that problem completely, but it's finding the funding. But that, I mean, I think the possibility, you can have 3D avatars. Pretty soon the avatars, they actually find that people, there was a study done recently, and people thought they were given the choice of interacting, or they were assigned to either the avatar or the human condition, and they found the avatars actually to be more empathic than the humans, which is a little bit unnerving. But I think AI will help us address that.
Interesting. Thanks. Dr. Mason?
Yeah, thank you for that talk. So I was interested in the graph that usually goes by the New York Times.
Yeah.
That didn't really receive.
Correct.
Has there been any work delineating that graph more like by state? And then my other question is, the rest of the world seems to be pretty similar.
The rest of the world had a similar increase. I don't know. I'm sure they could get those data available by state. I actually went on the website to look up. There are certain states that you might guess that would have higher alcohol consumption, so that would be available. Yeah, it's a pretty stunning graph.
Mm-hmm. Mm-hmm.
Yeah. I mean, $1 billion, you know, that shows you that, the extent of the stress during the pandemic and the ongoing stress that it hasn't reset.
That's impressive. Other questions? I'll ask, this issue of women, I think it was 30 to 40% as likely to come forward to seek help for an alcohol problem. Any sense of how do you understand that? What do you think that's about?
I think it's multifaceted for women. I think women are in the workforce and they're still doing more of the child care. So just finding the time. The stigma for women who drink alcohol, we did some early studies of just women being in a bar drinking, and men being in the bar drinking and both collecting opinions. And the woman who had had too much to drink was seen as loose and available for being approached for the rest of the evening, whereas men, it was sort of a sign of they were having a good time. So the stigma begins just around the alcohol itself. But it's very hard for women to bring this up with their providers. That's why careful and kind, measured screening for women is essential. I mean, half the people, we saw from the graph, half the people are drinking in the past month, men and women. And women are closing the gap. And I think the fact that their bodies are more susceptible to alcohol use harms makes it even more imperative that we be sensitive to them and how hard it is for women to bring this topic up. Yeah.
Yeah. Go ahead. Sorry, well, it was Dr. Schreier. Look, I was calling on someone else, but go ahead.
Go ahead.
I may have missed this earlier in the talk because I came a bit late, but there seems to be an increase in private equity companies kind of beginning to do this kind of treatment online.
Yeah.
Any evidence of their advocacy or kind of support for those kinds of models?
Right. So the problem with a lot of those programs is it's not psychologists or psychiatrists or someone with knowledge, a background in treatment and evidence-based therapies who's putting them together. And you can't, one person told me that they had set up a program like this, and she said, well, we just went online and pulled down the CBT manual and turned it into a computerized intervention. And as you all know, it's not just the mechanics of the manual, it's also, you want your computer to sound like somebody who's delivered treatment. And you also want the computer to sound, the responses that are a menu of options, you want those to be things that actual patients say. So it is the Wild West out there.
Thanks. Yeah, go ahead.
Yeah, I remember reading about that. I think we have to be very careful when we work with our patient population that we have a variety of different avatars and that people can choose their avatar. So our avatar that we developed, Dr. Edna Poe, who is our first Baltimore avatar, is based on a provider from the HIV clinic, from the Bartlett Clinic, and we tested her a lot to make sure that she was liked, that she was perceived as helpful, and not just go in and just create an avatar that is our image of what's going to be a good one for a setting. And so each setting we go into, we can make new avatars, which is pretty exciting. But yeah, AI, well, I have some thoughts about that, but I probably, it's, you know, you have to look at who's generating it, and, you know, we have to be very, very conscious about it because AI is not going to be. Not yet, anyway.
It does make sense, this idea of basing an avatar on someone who you think is an incredibly good clinician.
Yeah.
Modeling it after a particular individual like that makes a certain amount of sense, which also conceivably could explain why the patient might have a sense of anthropomorphizing the avatar,
Absolutely.
you know, sort of seeing the person behind it.
Well, and in fact, our brains don't discriminate avatars from people if you do a good job. They've done MRI studies and found it lights up the same part of the brain. So we're not sophisticated in our brain response, which is kind of interesting.
Yeah, Dr. DePaula.
Yeah, thank you, Heidi. Wonderful talk. And just want to mention the issue of adding depression to the system, and that is that at least at the time of the initial ECA study, 2000, whatever it was, or no, 1984, sorry. And there was the cohort, at least in Baltimore, was studied, and it was an interesting difference between men and women, and that is that based just on amount having drunk per day, women were 5
Exactly. Yeah, actually, I'm glad you brought that out because when you asked the question about, sort of why are women different, because I've got a lot of thoughts swirling in my head right now, I didn't mention comorbid depression, which is a real driver for women. And in fact, when we've collected all these reasons on our computer interventions about, why do you drink? And women are much more, it's relief from pain. And men, it's to be out being happy with their bros. It's a very different driver.
Great. Thanks. Other questions? If not, we'll thank Dr. Hutton
Thank
for
you.
a really great grand round.